My name is Safiya Lyn-Lassiter. So I am an emergency medicine physician currently practicing in Miami, Florida. I've been down there for almost 9 years now. And in 2016, going into 17, cannabis became legalized medicinally. So I have a company called Ask Dr. Lyn, where I help patients acquire their medical marijuana card. And that is in Florida, also in the state of California, and also in the state of Georgia. So let's get right into it. This topic is very special to me because I could only reflect on this post-residency. While I was going through it and while I was in residency, I didn't even view it as a challenge. I just viewed it as this is what I had to do. This is the normal. This is what women endure. If you want to have children and have a family while you're in residency, this is the practice and you just kind of have to deal with it. So it really wasn't until some years afterward that I realized I actually made it through. I actually survived. And beyond that, I was successful and an awesome mom, which is a testimony to my amazing kid. And, you know, a pretty dope doctor. Like, patients love me. I'm excited about my work every day. And 9 years later, still here practicing and encouraging other women and other students to get involved in the field. So let's get into it. Goals and objectives. Residency programs have parental leave policies, but many do not have formal support structure beyond the demands of residency, including pregnancy, maternity leave, and in some instances, breastfeeding. A knowledge gap exists regarding ways to support residents beyond the immediate birth of a child. Residency programs often require adherence to fairly inflexible schedules and do not often address work-family balance, which is what we all hope to ultimately achieve. The purpose of this conversation is to gain a better understanding of the experiences and perceptions of parenting amongst medical residents regarding their roles as parents and physicians. Essentially, I want to hear from you all. I want to hear how your experience was, how your experience with your program directors was, with your co-residents, and understanding how it was in that moment and how you can feel removed from there now, when you can reflect back on it. What are some of the goals and objectives for our talk today? Number one, to understand the current parental leave policy and how it impacts medical residents. So what is that? What does that look like in 2021 and 22? Number two, raise awareness for the physical and emotional effects that women physicians endure by having children at a later age in life. Number three, I want to offer residents effective strategies for navigating difficult conversations surrounding family planning, pregnancy, parental leave, postpartum, and return to work. Because ultimately it's beyond just having a child, right? Okay, you go to the hospital, drop the baby, 6 weeks later, you come back to work. We also have to discuss what that looks like, because now you're in a totally different role. So what kind of support do you need now? And finally, I hope to suggest feasible interventions designed to reduce discrimination against childbearing physicians. Oh, this is me at 9 months. The dark hair, the big belly, oh my gosh, yes. I had an amazing pregnancy, thank God, healthy, did well all the way up until the very last day I was on rotations. So it was an awesome and very caring pregnancy on my body. Most women are not afforded that opportunity. They have very challenging pregnancies, whether it's first trimester or final trimester. It's a very challenging physically. And on top of that, you have the emotional stress. So thankful and grateful for an amazing experience, but I had no other option other than to push through. So when I look back at this picture, and gosh, I was 27, 28 at the time, and just kind of thinking like, how the heck did I make it? Being a fourth year medical student, getting ready for residency interviews, application season, match day, and then also getting ready to enter my first year as a brand new physician, a new mom, and a new wife. So this was a very complex time in my life, and I hope to be able to celebrate it, you know? But in the moment while I was in it, I was too busy trying to navigate all the different spaces and I couldn't really enjoy it. So you see me smiling, but on the inside, I was definitely struggling. So I want to make sure that this is a moment that women can appreciate. One of the research studies that I came across while I was getting ready and preparing for this lecture today is parental leave policy information during residency interviews. So remember that season in your 4th year when you're getting ready to interview, you're like, what do I wear? What's the right color? What should I look like? You know, which one should I accept? Which one should I deny? That season is very challenging in general, much less what questions do I ask? What are safe questions? What are not so good questions? Are the other residents interviewing me as well? Like, how does that feel? What does that look like? So beyond just feeling like, do I like this institution? There's a big question and a big concern, do they like me as well? This study had a cohort of 27 program directors that responded and almost 180 medical students. They found that 70% of program directors state information on parental leave was not provided to candidates. And the most common reason why they didn't give this information was because they said it was quote unquote not relevant. Whereas 92% of interviewees desired this information. They wanted to know, but over 60% didn't ask because they felt uncomfortable. So you have the desire of wanting to know more, but the fear of not actually speaking up and asking a simple question about your parental leave policy because you're uncomfortable or you're worried about what they're going to think of you, what your reflection might look like. Are they going to rank me lower because I'm interested in becoming a parent as well as being a physician? 61% of interviewees felt that this policy, knowing this policy, would have an impact on how they rank the program. So remember, not only do the programs rank you, but you rank the program as well. So had I known the policy for that particular institution that I was interviewing for, how would I rank that program? If you knew that they were more supportive of families, would you rank them higher? If you knew that they were not as family friendly, would you rank them lower? You know, that's something to really think about. In conclusion, who is to make that decision? It's not the program director to decide if this is relevant or not. It's not for the student to say, I'm uncomfortable, so I'm not going to ask. Put the information out into the universe, make it public, make it available, and then let the interviewees decide, do I want to utilize this? Do I want to access this? Do I want to tap into this? For my own knowledge, FYI, males and females, because remember, you have parental leave, which is inclusive of fathers and mothers. So what does that look like for you as a new father? What does that look like for you as a new mom? Let's bring it all into context. 83% of program directors believe becoming a parent will negatively impact your residency performance. Over 80% of program directors believe that. That's super high, right? So imagine that you're already walking into a space feeling like I'm a fish out of water. I don't know where I'm at. And then on top of that, compounded, your superiors, your program directors are not supporting you because they feel like you as a new parent are not going to perform at your highest quality and ability. Enrollment of female medical students is over 50%, right? So we're meeting you. We're half and half with men and women at this point. Women have increasing numbers of childbearing at this stage. So during medical school and during residency, about 35% are having children. More than 7% of medical students graduate from medical school with at least one non-spouse dependent, and the majority of them look like children. So a non-spouse dependent, let's clarify that a little bit. A non-spouse dependent can be a parent who you now have to take care of, a younger sibling or an older sibling with some kind of medical condition, some kind of inability or disability that you've now assumed care for. It can be a partner who's recently become ill that you've now cared for. Your role and your dynamic has changed. So when they say non-spouse dependent, remember we're in COVID and a lot of people have joined households in the economics of savings, in the economics of support for each other. So your quote unquote normal household or traditional household no longer just looks like two parents and a kid and a dog, but you have a complete family living together for social support, for emotional support, for, you know, the pooling of resources in one single space. Of the 199 medical schools in the United States, 65 or 32% of institutions offer a parental leave policy for medical students. That's super low. That's not encouraging for students to have children during those 4 years of medical school when you don't have a policy that's available on your website. The specific residency program specialty board ultimately determines the policy on parental leave. Women already wrestle with the feelings of guilt and anxiety and embarrassment surrounding pregnancy. So being a medical student or a new resident doesn't make it any easier. You have all of those internal feelings which are magnified when you're walking into an unfamiliar space. And on top of that, not feeling supported by your program. Parenting during residency increases stress. Women who become mothers are emotionally, physically, and professionally impacted, more impacted than men who become fathers during residency. Social pressure resulting from traditional gender constructs deeply impacts how women residents choose to engage in parenthood conversations. So not only are we talking about the planning of having children, the delivery of your child, the post-care for yourself, the arrangement of care for your children once you go back to work, all of these conversations are not lended to a friendly platform when you're in an environment where you don't feel supported. 63% of women residents worry about burdening other colleagues as a result of taking maternity leave. How crazy does that sound? I'm worried more about my colleague or my co-residents than I am about taking care of myself. I just delivered a baby a few weeks ago, a whole baby just came out of me. But I'm more concerned about how that's going to impact my residents and my team than I am about celebrating that moment in my life, that milestone in my journey, right? 1 in 4, that's 25%, ladies, 1 in 4 women physicians across all medical disciplines, 25% of women physicians report a diagnosis of infertility. That's a really, really, really high percentage. When you think about the national average of infertility amongst women in general in the United States, for ages 15 to 44, the average is 6%. Now you're telling me medical professional women who are in this discipline, 25% of them have concerns or issues with infertility. That's a huge, huge number. Why is that? I'm happy to share all of my resources. I'm happy to share everything at the end of the lecture so that if you want to ever look these up or get some more information or get more details about the studies that I chose to grab some of these numbers from, I'll be glad to go into more details. What's the goal? What's the goal of this entire thing? Why are we here? Why am I here? Why did Isabella bring me here? I had the pleasure of speaking to the emergency medicine group at Nova Medical School in Davie, Florida, a couple of years ago. And I honestly didn't even, think about it like that. It was just a very informal meeting. We had a great turnout and I was speaking candidly about my journey. And I mentioned during that time, I had my daughter and my niece with me. They were like 10 and 12 at the time. They're playing around in the front row recording me. And I mentioned during that time when I was a resident, it was super hard and super challenging. And it resonated with so many of the female medical students, especially. And I got such great feedback and so many questions. And they were like, how did you make it through? How did that impact you? What did you do? Just wanting to understand, a little bit more about those struggles, those insecurities, those feelings that I had at the time. So I realized it's a bigger conversation than just, an informal lunch and learn in medical school. It really is a bigger discussion. And it's a discussion that many women are afraid to approach because they should appear to be career driven and less family driven. And there isn't a balance between your family life and your work life. And it's really not respected. You do great work as a doctor. That's where you're respected in your field of medicine. You're not respected by being an amazing mom. So it's something that I hope to find a medium of support for each other and understand that you don't have to choose. You can do both. And both comes with sacrifice, both comes with time commitment, but understanding that in life, there are benefits to when you decide to have children, doing that earlier in life or choosing other fertility methods and prevention methods earlier in life as opposed to later. So I want to get into some of that detail. My ultimate goal for this entire lecture is to create an equitable residency experience, free from the stigma associated with pregnancy and parenting. Let's read that one more time. To create an equitable residency experience, free from the stigma associated with pregnancy and parenting. What does that look like? Let's open up the floor to some of our guests in the room. What does an equitable residency experience look like? How many students do we have, first of all? All right, 3 students, wonderful. And then professors or physicians or training and guests, thank you everyone. So equity is a really key word here, and I highlighted and underlined it in red because I wanted to really emphasize the importance of this experience, because not everyone feels that it's a fair experience, especially for women. They feel like they're really torn during those 3 to 5 years of residency while they're trying to family plan and life plan, but also be amazing doctors. Who are these 2 guys? Anybody recognize them?
Cheating a little.
Yes, tell me.
I know one of them is Osler.
You got it. Which one? The top one or the bottom?
Go with the top one.
You got it, the bald head. Yes, that's Osler. And then that's its homeboy at the bottom. What's his name? Halsted. So Doctors Osler and Doctors Halsted, they are the 2 physicians who started the very, very, very first residency program in 1889 at Johns Hopkins. So we're talking over 100 and almost 30 years ago, right? In 1889, what did residency look like then? Were there even women in residency at that time, right? A very different picture and lack of diversity at that time. Let's get into the timeline. All right, so in 1980s, residency programs started to formalize policies regarding parental leave. This is just 40 years ago. We're not talking about 50, 60, 80 years ago, 40 years ago, they just started to formalize policies. At that moment, the initial focus was only on maternity leave. So this policy really only included women, right? It didn't talk about parent leave for men. It didn't talk about leave for children who are adopted. It didn't talk about leave for caretaking of yourself or a family member or anything like that. It was strictly maternity leave. Finally, in 1993, FMLA, the US Family and Medical Leave Act, was established to minimum requirements for parental leave for all quote unquote employees, which was up to 12 weeks for parental leave with continuation of benefits and protection from employment. Do you think you're getting paid for the entire 12 weeks while you're out? No, you're not. So what that 12 weeks guarantees you is the option to decide, hey, I want to take 12 weeks off or up to 12 weeks, 10 weeks, 9 weeks, more than the standard 6, and I can't lose my job. So you're protected under FMLA, and that was effective in 1993. Now there's some key things here for all employees. In 1993, residents were considered students. They were an extension of medical school. They were not considered employees yet. And the next point makes that FMLA stipulates that individuals must have worked for at least 12 months or at least 1 year to be eligible for coverage through their employer. So now we're talking about first year residency. You have to be employed for at least 1 year before deciding to use your FMLA leave and to guarantee that you're going to have a job when you get back. How does that affect transitional programs, which are 12 months? Transitional year is a 1 year in between while you're moving from medical school into your official residency. That's only a 1 year program. So does that mean that now newly fresh out of medical school residents don't have the benefit of FMLA because the program's less than 1 year and they haven't worked 1 full year yet? What happens if you decide to get pregnant before going into residency and ends up delivering during that time, your transitional year? What happens to you? You are in this gray zone. In 1995, the first policy outlining leave for non-childbearing parent was created. So here we are, a couple years later, we're starting to be more inclusive of mothers and fathers who adopt, more inclusive of those who inherit stepchildren by marriage, things like that. But the language is becoming a little bit broader in the respect rather than only talking about women who give birth to children, right? Residents are now classified as employees instead of students in 2004. That was just 16 years ago. You just became an employee. So now you're able to take advantage of some of these benefits. By 2005, formal policies surrounding maternity leave were instituted at 90% of non-surgical residency programs. So by 2005, we're getting into the 21st century, and you're like, okay, we need something in paper. We need something writing. Finally, last year, July 2021, this was not even 9 months ago, last year, the American Board of Medical Specialties developed policy on parental, caregiver, and family leave during training. So we're going to explore that a little bit deeper. What does that look like? And you need to know it because it directly impacts you, and it directly impacts your spouse and your family. This was just last year that this became implemented, so it's super, super new. Remember that, the American Board of Medical Specialties, ABMS. Quiz hints, okay? All right. What are the top 10 US first-year residency positions? Well, we know internal medicine has the most first-year residency positions, over 11,000. So they're always going to be number one. But right after that, you have family medicine. Third in line is peds. General surgery has almost 3,000 first-year residents. Finally, ER, which is me, 2,739. And then it gets smaller and smaller and smaller. Overall, 35,000 first-year positions are offered. And that was most recently as 2001. And remember, 50% of those positions are women, right? So of the first-year medical residents, 35,000 positions are offered in the United States, and half of that is women. Let's get into the medical specialties with the most and the least women physicians. Highlighted in pink are the ones with the most women physicians, and highlighted in blue are the ones with the least women physicians. Many, many, many women delay childbearing to attain specific career milestones and may result in increased rates of infertility, adverse pregnancy outcomes amongst physicians. Conversely, having children earlier while in medical training is challenging and may influence a trainee's career decision. Assumptions regarding how a physician's priorities will change when they bear children may result in fewer career opportunities and encouragement to pursue quote unquote family-friendly specialties. Yet, the onus is placed on women physicians to succeed in a profession that historically excludes women and has only recently acknowledged the importance of physician wellness and cultivating personal fulfillment. Remember we talked about this American Board of Medical Specialties and the policy on parental, caregiver, and family leave during training. So what does that look like? So this was implemented in July 2021, and I'm going to read you some of the key points on here. Not the whole thing, you can definitely look it up online. But key points are residents and fellows, so it's protected for residents and actual fellows as well too, will be allowed a minimum of 6 weeks, quiz word, 6 weeks, away from medical leave or caregiving once during training without having to use vacation or sick leave and without having to extend their training, according to ABMS. The American Board policy that accommodate reasonable leave of absence from residency and fellowship for training and purposes include birth care of a newborn, adopted or foster child, that's the parental leave portion, with an immediate family member, their care, including a child, a spouse, or a parent, and a serious health condition of the caregiver, or the trainee's own serious health condition, the medical leave part. So those are the 3 components. You have parental leave, caregiver leave, and medical leave. And those allow you a minimum of 6 weeks to be able to step away from your program and focus on your family and yourself. This is only allowed 1 time during your fellowship and residency. So God forbid you want to have 2 babies, right? God forbid you want to have a baby in your first year and then maybe another one in your 3rd year. You're only allowed this 1 time. Otherwise, you're at risk of having to extend your program or lengthen your program in order to meet all the requirements and fulfillments for that program. Or you might have to actually dip into vacation time. Policy applies to residents enrolled in training programs of 2 or more years duration. So remember, we talked about different programs having different lengths. So it has to be a minimum of 2 years in that program in order to take advantage of this. The policy applies to residents who meet eligibility requirements for initial certification. And remember, this ABMS policy does not supersede the institution's policy or state laws. So you have as a foundation, the ABMS policy, then on top of that, you have the specific institution policy. Then on top of that, you have the state laws. So you're compounded by all of these other entities that have an influence on your personal well-being, on how you care for yourself, on how you care for your family, on how you choose to care for your child. These are all super important factors. This is just a list of certain resources that I used while preparing for this lecture, including Family Medical Leave Act, talked about disbursement agreement procedures for physicians and dental residents, common program requirements, et cetera, et cetera. I can provide this in more detail. Let's make it a little bit more personalized. Why is this journey even important to me? Why am I here talking about this? Specifically, when I was in medical school, I got pregnant in my 4th year of medical school. And I was very early in my first trimester while I was interviewing. And I was so scared that they would find out I was pregnant. It was like a biggest fear for me. I didn't want to talk about it. I didn't want to celebrate it. I didn't want to mention it. I'm like, oh yes, I'm here, single, you know. I didn't want to bring it up, and nor did I want anyone to ask, do you want to have kids? Are you interested in having kids? Because I thought immediately that they would think that I wasn't committed to the program. And I was going to either take time off or leave the program. So I was in such a bind and so torn because I really, really, really wanted to be a part of this community and family and this residency program. But I also really wanted to have children, and I really wanted to be successful at that, and my marriage and childbearing and, you know, caring for my daughter. So it was a very tough position to be in, and I didn't tell anybody. So I kept it a huge secret while I was interviewing. So I'm going through that stage. Now here we are, match day, and I'm like, okay, yay, I got in, awesome. My anticipated delivery date was October, and match day was in March. So, you know, you get matched, you sign your contract, this is where I'm going, this is what I'm gonna do, awesome, you have a sense of accomplishment. Then we get into graduation. Graduation is usually around May. Graduation, I'm like 5-6 months at this time. So I'm like, all right, what are we gonna do? Then I decided at that stage, I don't wanna drop my kid in October and continue working 6 weeks later. Like, I wanna have some time off and enjoy this first year being a mom. So I deferred my residency, and I took a year in between medical school and starting my first year residency. So I graduated on time, I got out of there, I was able to deliver my daughter, healthy, successful delivery, everything went great. And then I spent the months between October when she was born and July, right before I started residency, just being a mom. When I told my program that I was going to defer a year, they were like, you know how many people wanted this slot? I was a female, a Black female emergency medicine resident. I just told you there's only 2,700 positions for emergency medicine, and 30% of those are women. So less than 600 slots for female emergency medicine residents in the country. And then on top of that, I'm Black. So between race, between gender, between going for a specialty like emergency medicine, they were looking at me like, who does that? Who takes time off? Who defers starting their program? So I had a lot of stigma before I even got there, before I even set foot in the door. Remember, I had been out of training for almost a year at this point. I hadn't touched a patient in months, you know? So slowly you begin to kind of lose your skills and you have to brush up on stuff. So I was playing catch up when I first started. And then I was also learning my daughter at 8 months now, okay, we're no longer doing this kind of feeding. Now we're into rice, and now we're into cereal, and now we're into milk. Like we're kind of transitioning with her diet and her needs. And then me becoming a brand new resident and a doctor where it's on my license now. I can't say, oh, I'm a medical student working with Dr. such and such. No, I'm the doctor showing up. You know, when the code happens, they're not looking for the attending, they're looking for me. So I have to be there. So the responsibility of being a brand new medical resident in a specialty where they know I have a brand new baby and they're already looking at me like, you deferred, you're late to the game, and now you want to show up. I had all of those stigmas, you know, before I even started. So it was really important for my work to shine. And it was really important for me to do great work. And I really prided myself on that. You know, residency is a time where you build a family with a team because you're all struggling, going through the same thing. But I couldn't enjoy those moments at the bar after work, or I couldn't do certain things with them. And I couldn't really bond with that group because I was rushing home to see my daughter because I was trying to make, you know, snack time and bedtime before she went to sleep and trying to catch those precious moments with her. So I also felt isolated and disconnected from other residents because they didn't have children. So it was a huge transition for me, and it weighed on me emotionally. It weighed on me physically, and it was very hard. Not gonna lie. But I made it, and we're here to tell the story, and we can celebrate graduation day in 2010. I went to Morristown Medical Center in New Jersey. I'm from New York originally, so it was like going back home. Super happy because I had the support close by of my husband's family. My sister, who's with me today, Jamila, would fly in all the time from Atlanta, Georgia, to help me. And then my mom would come regularly as well, too. So we had a great tribe set up. That tribe was here to make sure that I was able to do everything I needed to do without question. These are my mentors. These are my actual mentors and attendings that I worked with. This picture was taken after I graduated when they invited me back to give a lecture at Grand Rounds on CBD and THC. So this is Morristown Medical Center. These are the doctors that trained me, the doctors that worked with me, that held my hand through the process, that belittled me, that told me that I need to do better, I need to brush up, I need to read more. You know, they gave me no excuses and absolutely, you know, no reason to say, just because you're a woman, just because you're a new mom, just because you're a new wife, just because you're having all these emotional struggles, no one cares. Suck it up and keep going. So they were hard. And to be in this photo with them today, standing as a peer, as a you know, as a part of a team, it was really special to me, especially because I was presenting on work that I was passionate about, that I learned outside of residency, that I really, you know, took the moment to self-teach. And this work was really important. And New Jersey was on the cusp of becoming legalized. So it was a really important conversation. So that's why I share this picture with everyone. But yeah, Dr. Silverman, Dr. Fiesler, these guys, they gave it to me the entire 3 years. 80-hour work week restrictions. 80-hour work week restrictions prohibits residents from working more than 80 hours per week, 24 hours per shift. You're required to have a 1 day off by law every 7 days and have at least 8 hours in between shifts. So there were no more 48-hour, you know, on-call shifts. Now they implemented in 2003 actual restrictions to build safer work environments to hopefully have less mistakes because you're not overtired. The impact of occupational shift work and working hours during pregnancy on health outcomes. This was a meta-analysis review that was posted in a American Journal of Gynecology. And it talked about women who worked rotating shifts. So sometimes nights, sometimes days, back into nights. So rotating shifts, fixed night shifts, meaning working more than 3 night shifts in a row, fixed night shifts, and longer hours. So 12 hours, 24-hour shifts were more likely to suffer adverse pregnancy outcomes. So specifically women in medical residency that experienced some of those things, including extended hours, fixed night shift rotations, they were more likely to have adverse outcomes. What are some of the adverse outcomes in pregnancy? What does that look like? Some of them include miscarrying, the ultimate worst thing that could possibly happen to you, preeclampsia, gestational hypertension, fetal growth restriction, and preterm delivery. Those 5 things were the top 5 adverse pregnancy outcomes. And then you usually saw that in women who worked these kinds of shifts. Women working more than 55 hours per week had a 10% increase of preterm labor. The unifying theme amongst all of these adversities is stress. The more stress you put on yourself, physically and emotionally, directly affects your pregnancy and your unborn child, which can lead to preterm delivery, preeclampsia, ultimately miscarriage. All of those things have an undercurrent of stress. You have to take care of yourself in order to be a temple to take care of your child, right? Pregnancy and parenthood remain challenging during surgical residency. This one is specifically for surgical residents, and it was posted in the Academic Medicine Journal in October 2020. It found that female residents had fewer children during residency than males. So about 28% of female residents had children during residency. Remember, surgical residency is 5 years minimum, some of them 6 because they want a research year. So about 28% of women who were surgical residents had children versus males, over 50% of them had children during that time. What's important about that? Why is that important? When we think about gender and we think about the role of parenting, who assumes the greatest responsibility for kids? Is it men or is it women? Women. Can we all say that's true? See everybody shaking their head? Yeah, the direct impact of having a child falls directly on the woman. Because if you decide to breastfeed, if you can't pump, those all impact your child and their feeding and their nourishment, you know? So not just, that, but emotionally and physically, we're typically held with the responsibilities of arranging for sitters, arranging for nannies, arranging childcare, activities, scheduling. All of those things typically fall on women harder than they do on men. As compared with the general population, surgical residents had their first year later in life. So average age of a woman in the United States having a child is around 25. For surgical residents, they found that they had children in their early 30s, between 30 and 34 years old. So they were delaying family planning and initiation. Female surgical residents had overall less children, less than 2, whereas the general population had 3. Infertility rates higher amongst female surgeons than the general population. So the general population infertility rates are about 11%, and the female surgical population, they're even higher than the general medicine residents. So we have medical residents, which were 1 in 4 at 25%, which we saw. If you're a surgical medical resident, about 30%, almost 1 out of 3 have infertility concerns and issues. Use of assisted reproductive technology is higher in surgical residents. Pregnant surgical residents experience a higher rate of obstetrical complications like pregnancy loss, over 40%. And some of those complications we talked about on the previous slide, right? Versus 20% across the general country. Overall, you find that surgical residents voluntarily delay childbearing during residency. This quote is really important. It's really important because I didn't want to fall into this statistic. I put this on here to make everyone aware that you go through 4 years of medical school, you go through anywhere from 3 to 5 years of residency training. And then imagine if you want to do fellowship afterward, another 2 years, 2 to 4 years, depending on what you specialize in. So you go through all of that to finally finish, to find that at the end of all of that, 40% of women either leave medicine altogether or go part-time within 6 years of finishing residency. Why is that? Why do we do that? The trends that they have found is that there are a lot of barriers to being a mom and being a resident. So once they finish residency, or within 6 years of finishing residency, about 40% of those women decide, I don't want to deal with those barriers. Some of them include gender harassment. That's real. Salary inequity, gender bias, evidence household responsibilities are greater for women physicians than men, discrimination related to pregnancy, postpartum or breastfeeding, and work-family conflict. These are really important barriers because we're talking about medicine, but we're talking about careers in general for women as well too. So it's universal that many women face cross-culturally in law, in medicine, in service industry. These are all things that women go through. But I found this fact to be astounding that we go through all this training and all these fellowships and all this specialization to just walk away. 40% of the women either walk away or they reduce their hours to part-time. How can we improve support for parents during residency? What does that look like? How can we make it so that 40% of these women do not feel the pressure or need to walk away after completing their residency? What can we do during residency? This slide is important for me because now I'm sitting on the other side. I'm now on the administration side and the academic side, and I'm helping residents. I'm at Mount Sinai Medical Center, and I have first year, second year, and third year residents that rotate with me, and I'm directly responsible for. And I really take the time to try to coach them and share my story and share my journey with them so they don't feel like they're alone in the process, and make them feel like they can ask me anything, because it's really the importance of having an allyship, the importance of having a mentor across different disciplines of medicine that help you to succeed ultimately. So how can I be of support to the incoming residents now in the position that I'm in? It's important to have clearly outlined maternity and parental guidelines readily available for residents. It's one thing to say, yeah, I got this policy. Okay, great, amazing. Where is the policy? How can I find it? Is it buried somewhere within all of the 2.567 section of AC3, Roman numeral 2? Like, where is this policy? It should be readily available so that everyone can access it if they want to. Acknowledgement of concerns surrounding pregnancy and parenting during residency. Respect the candidate's personal decision to have children and prioritize family. Establish gender equity in medicine. The absence of a maternity and paternity leave policy in residency is very insensitive. Increase the number of residency positions to ensure scheduling flexibility. Integrate reproductive health teaching for students in medical curricula early in training. Not only do you have to think about your physiology and your pharmacology classes, but you also got to think about your fertility, right? So now you're a medical student, which is your optimal time to freeze your eggs, your early 20s for most people. That's your optimal time. That's when you have the best quality eggs, you produce the most eggs. Like, that's something you got to start thinking about. If I do want to become a surgeon, that's 10 years away from now. I'm going to now be in my mid 30s. What would that look like for my body to start having children then? How would that be? How easy will it be? How hard it will be? So you have to start having these conversations with yourself and with others, as early as medical school. Integrate reproductive health teaching for students in medical curricula early in training, and foster allyship in the profession to reduce stigma. So talk to me, talk to people of different levels in your medical discipline, whether it is a attending physician, whether it's a program director, whether it is, other residents, third year, second year. Talk to them so that way you can understand, what does this look like? How did you navigate it? Everyone has a different technique that worked for them. This was a great summary from parenting friendly residency programs, that they did this survey to find what would be supportive of them. Some of the things that seemed super simple, but very hard. So in residency, you ultimately work any hours you need to. You don't have a 9 to 5. Most daycares are open at 7 a.m. and close at 6:30, right? So explore the possibility of parental leave or on-site daycare. Create child-friendly spaces within the hospital or clinic to make families with children feel more welcome to visit them during their breaks and during their meals. That's not hard, If your partner or mother or whoever's watching your child that day is able to bring them to the hospital and see you, those 5 minutes are invaluable, as opposed to waiting 13 hours till you leave work, and then by the time they get home, they're in bed. That can make a huge difference in the quality of life for the child and the bond between the mother or parent and child. Ensure policies for leave are well publicized. Flexible offerings for vacation time, including the opportunity to select individual or partial days off to attend children's events. You never hear that, you know? If I want to go to my daughter's first dance recital and use a vacation day, I should be able to do that as opposed to waiting till I have that 2-week block of time off. Be a little bit more flexible to say, hey, I want to use one of my 10 vacation days during this time. Is that possible? So simple little things that could make the environment much more friendly for residents, for program directors, for the general energy of the team to be successful. This is my family. I chose this picture because Myla was super young at the time. It was my first year out of residency and I was practicing in Miami, Florida. So now I had relocated from New Jersey down to Miami, where we didn't know anybody. We just started fresh. We were like, let's go to Florida. The weather's awesome. Taxes are good. Let's go down there. You know, all the things you got to think about. You're like, okay, I'm finally starting to make some money. Where can my money stretch the longest? So this is my amazing family. And let's move into our final thoughts. I know we're coming close on time and I wanted to leave a moment for questions and answers and, you know, make myself available afterward. I thank you all for staying with me. I know this has been a long day, so I appreciate you all hanging in there. Final thoughts. Pregnancy is not a handicap. So don't think because I'm pregnant, I can use that as my handicap for why I can't do certain things either. That doesn't fly. Create a support network, create a team. Plan ahead and communicate. Do not ask for permission, be unapologetic. So instead of asking your program director, you know, I'm thinking about getting pregnant, what do you think? Tell them, tell your program director about your pregnancy, you're planning for maternity leave and accommodating for breastfeeding. So instead of asking for permission or what they think or how that will impact them as a team, tell them, hey, by the way, I'm pregnant. This is my journey. My anticipated delivery date is going to be October 16th. During that time, I plan to be taking off anywhere from 6 to 12 weeks. I'll let you know closer in, but I know we need to plan. So how can I be helpful and make sure that there's coverage for everyone? So that way we can spread out the responsibilities, you know, and everyone can feel covered at that time and feel supported at the time, including myself. Prioritize your responsibilities. Number 5, do not expect special accommodations to be extended. Just because you're 9 months pregnant and you're waddling down the hall, you can't pick up chart 2 right next to you. You still got to go see chart 37 at the end of the hall, way on the other side of the hospital. So do not expect special accommodations. No one cares, bottom line. They don't care that you're pregnant. You still got to do the work. Finally, celebrate your journey. Affirm yourself along the way and beyond. This doesn't happen all the time. This is not something that you get pregnant every month and you're like, yay. No, this might only happen once for you or might not happen at all. So while you're in the moment and while you're in the process, enjoy it, celebrate it. It is new life. It is a new beginning. It is a part of who you are and it's a part of making you a more intuitive, amazing woman or man, right? So celebrate that journey and just know that what you're doing is important, it's valuable, and ultimately it's your decision. Let's do a couple quick quiz questions so that way we can get our credits. Name the board that created the standards for parental leave. Take a look, take a look. Shout them out. B should say American Board of Medical Specialty. Just a hint. Yes, exactly. Just a hint on that one. Just a hint. Yes, so it's B, American Board of Medical Specialty. That's my fault. I figured I'd give you that. I won't make you work hard for that one. But this one you should know. Parental leave policy allows for a minimum of how many weeks away from training? There you go. Excellent, 6 weeks, and that's nothing. Imagine if you had a C-section. You can't even have sex before 6 weeks. So much less you're supposed to be walking the hallways of, you know, yards and yards away to see bed 37. Like, just imagine 6 weeks is not a long time. How many first-year residency positions are available in the US, specifically in 2021? There you go, B. Or who said A? Almost, but B. It was 35,000. And remember, of the 35,000 first-year residency positions in the United States, 50% of those are women. Which one is not a result of the impact of shift work on pregnancy and health outcomes? Ooh, this is like a board question. Oh my gosh, everyone's awesome, good. And the reason why, we talked about stress being the unifying theme amongst all of these. Gestational diabetes is not influenced by stress. You don't get diabetes because you're stressed. It's more influenced by your genetics, right? And your makeup. Whereas preterm delivery, preeclampsia, gestational hypertension, and miscarriage are all influenced by stress. Finally, which one of these options does not support mothers returning to work? Which one? E? Extending training program? Are you sure? Everyone sure? Correct. I know, I almost got you. Yes. And the reason why is we can talk about paid leave, which is supportive, and it's a technique to help parents reduce the stress, financial stress, because you're being paid during the time that you're away. Breast pumping time without penalty. So you don't want to say, okay, I worked a 12-hour shift, but because I had to take 30 minutes out of that 12 hours to breast pump, I have to stay an extra 30 minutes afterward, right? So breast pumping time without penalty. On-site childcare would significantly help because we don't work normal hours. That's just a fact. Schedule flexibility. That's really important. If there were more residents, then we'd be able to have a greater pool to choose from to sub in or sub out residents and also make the schedule a little bit more flexible. But extending the residency training program goes against all of those things. Ultimately, we want to build in time to the residency so that women have the option to choose. If I decide to get pregnant and deliver during my residency, I will not extend my program duration, but instead I have time within my 3-year block or 4-year block or 5-year block of residency that I'll graduate on time with my class because there's built-in time for life. Things happen. You know, beyond residency, it could be caring for a sick parent. It could be caring for yourself. You might actually get sick. You might have appendicitis, or you might need surgery. Something might happen to you. Accidents happen all the time. So we never want to extend our program or make us feel like because we choose family or choose pregnancy or choose to childbear, we have to now delay graduation. Finally, this is my little one. So this is Myla at 12 years old now. This is her poodle Milo. So Milo and Myla, which she loves to death. We got him during COVID and he's been a blessing to our entire family. She does competitive gymnastics in South Florida, pretty awesome. And she is a sneakerhead, just like her mom. So you see her fresh Jordans. Just to recap, let's revisit our goals, make sure that we addressed everything that we wanted to in this topic. Number one, we wanted to understand the current parental leave policy and how it impacts medical residents. We talked about that. We talked about what this now July 2021 policy is that is deemed by ABMS, right? So we understand what that looks like. Number two, we wanted to raise awareness of the physical and emotional effects that women physicians endure by having children at a later age. We talked about those 5 points: miscarriage, preeclampsia, gestational hypertension, all of those things that can impact if you decide to have children later in life or under too much stress during that time when you are pregnant. Number three, to offer residents effective strategies for navigating difficult conversations surrounding family planning, pregnancy, parental leave, postpartum, and returning to work. I really tried to hit all of those issues because I want residents to understand that this is a conversation that's necessary. As challenging as it is, the earlier you bring it up, the earlier you address it, from the moment of deciding to interview at that space. While you're in medical school, if I accept your interview, I want to make sure that I can read your parental leave policy online. I want to make sure I feel comfortable during the interview course to ask any of the other residents, any of the attendings about parenting, family-friendly situations and environments that are conducive for, activities that where you can bring your kids or on-site childcare, things like that, so that I can make that conversation a little bit more special and easier to navigate and conducive. And then it's not just about being pregnant during that time and dropping the baby. Let's talk about postpartum. Let's talk about what that looks like, how much time I might lead off. How will that affect scheduling? What can I do? to help manage that with everyone, make sure we have a balanced, supportive environment so that I don't come back 6 to 12 weeks later and they're looking at me like, oh, now you're back, now you want to work. You never want to create hostility in your environment. You want to make sure that you're working as a team and as a family, and you have the support from your program directors, and that trickles down and creates a culture, right? And finally, suggest feasible interventions designed to reduce discrimination against childbearing physicians. So it's really important, especially in my role now. I am, 9 years into my career, and I've been practicing emergency medicine in Florida this time, and it's been an amazing state, but I'm much more sensitive and I'm much more conscious of my words, how I speak, the conversations that I, implore with other students, especially with the female students and residents, because I want them to know they have an ally. They have someone that's been through this process, and they have someone that's going to support and fight for them. I don't want you to feel isolated how I did during my process. And I share that. And I honestly don't think it's because they made me feel that way intentionally, but because they didn't know better. We're talking over a decade ago when I was in residency. And I honestly just don't think they had that experience with other residents, being new mothers or being new physicians, because typically in emergency medicine and some of the other specialties, you didn't have new parents as residents. That time was devoted strictly to the residency, and they couldn't imagine being a new mom or a new dad and also being a doctor at the same time. It just wasn't fathomable. So even though, people had gone through it before, they weren't as expressive, and they really didn't have the language or the tools to support me in what I need. And now that I'm in that role, I want to make sure that I always give back, and I'm always able to support other women and men in their journey. Finally, my name is Safiya Lyn-Lassiter. My contact information is there. If you are looking for me on social media, YouTube, Facebook, Google, and Instagram, my favorite, feel free to DM me at Ask Dr. Lyn. I thank you all. I thank you for this opportunity to engage. I thank you for this opportunity to share my personal journey and story, and especially thank you to Isabella for inviting me. It was a difficult PowerPoint to put together because it was so personal. Normally I talk about endocannabinoids or COVID-19 or something that's more popular in the world, but specifically speaking about my journey and how much it shaped who I am today and impacted how I practice was really eye-opening, and it was a nice way to reflect on that time. So I thank you for bringing that opportunity to me, and thank you for sharing the space. Available for questions. We're going to close out because I know it's 7, but I'm available afterward for questions. Thank you, everyone.